we'll pause for a moment and see if there's any questions. I don't see any in the chat. So if we don't have any questions, then I'm going to ask Dana, when he gets a minute, to share his screen, and we'll move into the first module of the morning. Thank you, Dana.
Okay, everybody. Again, welcome back. Yesterday, I shared that we were going to speed date the 9 common assumptions about restraint and seclusion, where this morning we're going to be speed dating, building a foundation of trauma-informed care in your organization. And by the way, I know a lot about speed dating, you know, between all my husbands, I do that speed dating stuff. So hopefully I'll get this speed dating right here. So Kevin, I thought it was important when she reviewed this morning about, you know, the overview of the 6 core strategies and how it's built on the public health prevention model. And really, when we understand trauma and actually implement trauma-informed care practices, that we actually are preventing. It's one of the most important preventive aspects of preventing restraint and seclusion. So next slide, we're going to start actually with a quote from our own Dr. Huckshorn. And this is what Kevin shared a couple of years ago. You know, that real customer service for behavioral health customers starts with understanding trauma and life experience of trauma. But it's actually for all customers who we serve, all the people, whether they be in juvenile justice or child welfare or schools or prisons or jails. We have to begin to support them with our own understanding. So the next slide, please. So we're going to yesterday we did brain science, and today we're moving that to cover these areas. We're going to cover definitions. We're going to do a little bit more on the prevalence of traumatic life experiences in different settings. And then we're going to get to that third bullet on this slide is kind of the meat, or if you're vegans or vegetarians, the tofu of what this is all about, some of those characteristics of what trauma-informed systems are and trauma-insensitive systems are. And then we're going to just briefly cover some of the critical factors related to trauma assessments. Note, as we shared yesterday, there are thousands of articles and training programs related to trauma. And this session is not going to be able to address all the different aspects. We're not addressing trauma of families or staff, historical trauma, generational trauma, trauma caused by racial disproportionality, racism, or culturally insensitivity. We're also not going to be covering vicarious trauma, which can actually lead to compassion fatigue. So, but we will be giving you the foundation of what's needed to really move to the next steps in your organizations. And I'm sure many of you are already doing much of this. Next slide, please. First, it's important to know and understand the definitions. Do you know trauma was recognized in soldiers in the Civil War? And they actually called it back then nostalgia or soldier's heart. I think I love that idea that it was the soldier's heart. They got it back then. And he was even recognized, of course, in World War I and II, where they called it shell shock or combat fatigue. But here are some of the current definitions. Many are still using the one from NASHBIT, and it's this experience of violence and victimization, you know, including all of sexual abuse, physical abuse, neglect, loss. But it's not just your own experience. It could be witnessing. And then back in 2013, it was updated with the DSM-5. And the person's response is going to include fear, horror, helplessness, and extreme stress that overwhelms their capacity to cope. And that gets back to what we talked about yesterday, that self-regulation, which is kind of the cornerstone of development, supporting people with that ability to cope. Next slide, please. And then we go to the International Classification of Diseases, which just last year included that it's an anxiety disorder that develops in reaction to this physical injury or severe mental and emotional distress. So all of these are actually normal responses to abnormal events. And next slide, please. So what are the types of trauma that result in serious mental health problems, serious inability to regulate oneself? They're usually interpersonal in nature, they're intentional, they're prolonged. They include the ones we just talked about. And again, witnessing, don't forget witnessing. And they often occur in childhood and or adolescence, and then may extend over the individual's lifespan. There was an interesting study done, a very sad study done in South Carolina, where they were looking at homeless women, and they found that 97% of homeless women actually had history of severe physical and or sexual abuse. But what makes it even more tragic is that 87% of those continued to experience this abuse into adulthood. Remember when we were talking yesterday in neurobio about the Broca's area of the brain responsible for speech, which often will kind of be compromised when somebody's in the midst of trauma or experiencing trauma. And it's that loss of voice and that loss of actually choice with PTSD. So they lose their ability perhaps to say no, lose their ability of that rational functioning of your brain, of the cortex and hippocampus, to really get yourself out of situations that are dangerous. So next slide, we actually shared this slide yesterday. It's important to for all of us to continue to remember that post-traumatic stress disorder is characterized by internally re-experiencing the event. We're not able to see this in the persons we're serving. It's an internal re-experiencing of that event. And they have this, can have avoidance and numbing. And then the next slide, and this is extremely important to remember, that PTSD is characterized by mood and cognition negatively impacted, but it's that hyper arousal, exaggerated startle. How many of you have actually experienced in your program somebody losing control? All of us, right? This is who we're serving. And so this is what we're seeing often when somebody's losing control, is that it's that part of their PTSD. And so, we really appreciate, next slide, please, people like Dr. Jonathan Shea, who from his work with veterans, he shared that actually, if somebody has a broken bone, we don't call it a broken bone disorder, right? And so he's asking also, PTSD should not be considered a disorder. It's a psychological and emotional injury. It's a natural reaction to an unnatural situation. So we're trying to move it out of pathology, but we demand diagnoses, and so we have it. But remember, it's a natural reaction to this unnatural in this really unfortunate situation. So some definitions. Now, next slide. Here's a definition of trauma-informed care. It's treatment that incorporates that appreciation for the high prevalence. And all of you now have that, and maybe you had that before. Make sure everybody in your program has it. It's a thorough understanding of what we covered yesterday, that neurological, biological, psychological, and social impact of trauma, and the need for us to recognize, realize, and respond appropriately. So next slide. And here is our definition of trauma-informed care. What we're really wanting to do, again, is realizing the prevalence, recognizing it, responding, and asking everybody when you come into work. And again, I appreciate this, Kevin, when she was commissioner in Delaware, that she went around and actually met with staff from all different types of treatment programs, hospitals, community programs, everything. And she used that bad day. We have to be so on. If you're having a bad day, maybe stay home, because when you come in here, we need gentleness and kindness. So we have to really attend to this. We actively resist re-traumatization in any way. Dr. Maggie Bennington Davis eliminated restraint in her hospital in Salem, Oregon. She was the medical director. And she would always be called if it was nighttime, if there was a restraint, and go on to the unit if there was a restraint when they were moving towards elimination of restraint and seclusion. And she said when her staff would call her in the middle of the night and say, you know, we had a restraint, she would say to the staff, I'm sorry, it's my job to give you the tools you need so we don't end up in a restraint. What do you need? Do you need me to come in now? Can I support you in any way? So it's not, when we have that approach, it's not just with the people we serve, it's actually with each other. So we'll need to move from just trauma awareness, which is some of the things we did yesterday, to being more trauma focused. But be careful, just because we implement some clinical evidence-based trauma-focused interventions doesn't mean that we really have a program that's trauma sensitive, and truly trauma informed. Because what happens, I've been to, you know, like I know I look 25, but I'm 102 or something. And I've actually worked with staff in every state in this country and a couple of other countries. And what I found, and I'm going to be in the Guinness Book of World Records for having visited the most residential programs. And I found programs where the clinical staff are implementing evidence-based trauma-focused treatment interventions, but they have extremely high rates of restraints because the rest of the organization has not really taken up this issue of trauma. And it's almost more important to get to that trauma informed, where that organization is really committed to this entire framework. So we have to really understand just doing one piece isn't going to be enough. And we're continuing to improve. Next slide, please. So what does the prevalence data tell us for people from all different types of systems? Let's go look at it again. Next slide, please. So some of the prevalence for mental health population of adults. So look at the study in the community mental health centers in South Carolina. You know, there's most of the people we serve have multiple experiences of trauma in the mental health system. Next slide, please. And look at this second bullet. The majority of adults diagnosed with bipolar disorder, 81% were sexually or physically abused as children. That tells us so much. And how about with dissociation identity disorder, 90%. So when we're serving that adult population, any population, and they have, you know, whether they have these diagnoses or others, it's gentleness and kindness. Next slide, please. And then, is this data tragic or what? You know, when you think of people who have substance abuse challenges, so many of those homeless people who are, you know, have these substance abuse challenges, 2/3 of men and women in substance abuse treatment report childhood abuse and neglect. Look at that. You know, 50% of women in substance abuse treatment have history of rape or incest. It goes on and on. Let's go to the next population, IDD. So when we think about this group, they have little voice. And it's just unbelievable, really, when you think about it, that when somebody with intellectual and developmental disabilities comes into the system, their risk of abuse increases. So it's on all of us to focus on voice, to support people in understanding that they can share, and of course to be so careful. You know that we started this whole talking about trauma yesterday about Dr. Glenn Sachs saying do no harm. And so obviously with this population, we have been doing a lot of harm. And not only that, it's widely believed to be underreported. So very careful there. And then I wanted to also, let's go to the juvenile justice, but I want to say something. We don't have a slide here on child welfare. But they've done some really interesting studies on child welfare. And one of the studies that I just wanted to mention that isn't on the slide deck right now, but they did this was the Casey Family Programs, and they actually looked at people who were adults now. They had been in foster care for 1 year only between the ages of 14 and 18. And so a number of people in your hospitals have been in foster care, okay, when they were younger. And the PTSD rate for those adults who had only been in foster care for 1 year, okay, was higher than the rate for combat veterans. So up to 25% of the formerly foster care youth who are now adults met PTSD criteria. And that is only 12 to 13% for the Iraq War veterans and 15 for Vietnam War veterans. So not only juvenile justice, which you can look at here, and it's just devastating. 70 to 92% of incarcerated girls report sexual, physical, severe emotional abuse. Arrest rates are up to 8 times higher for youth who have a history of trauma. And it increases the likelihood of arrest by 59%. Next slide, please. And actually, the majority of youth in this system report multiple types of trauma. So know that if you work with juvenile justice or serving youth who've been in the juvenile justice system, we have serious challenges here. So the next slide is from two Jameses, James Gilligan and James Garbarino. James Gilligan's prison research is powerful, and he identifies shame and humiliation as the core element in violence. I had the gift of going to Arizona State Hospital a number of years ago. They were actually having troubles with the restraint and seclusion. So asked for data, as Kevin talks about the importance of data by unit before going out there. And one unit, which was the admission unit, actually had hardly any restraints or seclusions. They had the lowest in the entire hospital. And you would think they would have the highest because people are coming from county jail. Some of them have experienced, really unfortunate situations in those county jails. And so in talking to the staff on that unit, like, how do you do this? Well, they said, they asked all of the people, who they serve, what's your biggest trigger? And they said something like, and they continue to ask that, but they said that something like 99% they were saying their biggest trigger is lack of respect. So they decided to do their entire unit based on being respectful, not only with the people served, but with each other. And they even went to that to understanding that many of the people were coming from jail, they were coming from prison. And in prison, you don't want to be followed around. And so people didn't like this idea of a one-on-one that people served. And so they actually went to zone one-on-one because they don't want to shame, they don't want to humiliate, they want to show respect. And then James Garbarino, who was at Cornell University, and he studied violence with boys around the world. And it's just interesting what he's finding too is that they have this antisocial behavior that can regain control through aggression. So just having that at the bottom and understanding what all of that means is important. And then the next one is correctional settings. It goes back to the importance of dampening the amygdala with comfort, kindness, voice, and choice. So people with pervasive feelings of not being safe, which is exactly what you have in prison or correctional settings, have this state of chronic threat, requiring them to frequently use or resort to a physical aggression. So what is the next slide? What does that prevalence data tell us? The majority of the people we serve not only in psychiatric treatment settings, but in all of these other settings, and many of the schools also serving children who have these same challenges. There's a strong relationship between being victimized and later offending, and they're across all systems of care. So as next slide, we need to presume, which Kevin shared yesterday, that the clients we serve have a history of traumatic stress and use what we are calling universal precautions. Liz Murray, some of you may have heard of her. She wrote the book and there was a movie, Homeless to Harvard. And what she talks about is the muscles you use get strong. And so your job is actually to ensure all staff are focusing on that strength base and the hope and the resiliency for the persons we serve. So now we're going to get to what I call the miracle study. I wish I could see you guys waving, but how many of you are familiar with the ACE study? This study started nearly 30 years ago. It started in 1995, actually, by an organization called Kaiser Permanente. And it actually was with middle-class families. And what they were some of the doctors were actually beginning to see some of their patients were not getting better with different physical health ailments. And so they began to study this, and they began to see, the next slide, please, a correlation between risk scores or adverse childhood experiences, which is what ACE stands for, and different types of health issues. And these are just some of the health issues that they saw. When people have adverse childhood experiences, it increases their risk for health issues, mental health, physical health issues. And if you ever have some time, Google it, go around, look at some of the data is still being mined, it's still being updated. So here is just some of these slides that we picked out for you to look at. So this is the number of risk scores they have. So it could be physical abuse, sexual abuse, divorce, poverty. But so if you have 4 or more, your likelihood of attempting suicide, look how high it goes up for those who have 4 or more risk scores versus 0. Let's go to the next slide, please. Look at chronic depression for women and men as adults. Look at their risk score, their likelihood of having chronic depression. It really helps us. We used to blame people for their behaviors. Now we know, because of this important study, ACE, that the behaviors that present are directly related to the events that happen to them in their lives. So look at this, the experience of rape. We talked about this with the South Carolina woman. Look at almost 35% likely to be raped. Think of that Broca's area of the brain. We don't give voice and choice. We have to support people in gaining that back. Okay. Next slide, please. Smoking. Look at just smoking, your likelihood of smoking. Next slide, please. So you guys are going to have these. And then, of course, alcoholism. And what a sad, sad, sad piece, right? To think of so many people who suffer from alcoholism and then even substance abuse. One of the ACE studies talks about different examples. And this is, they gave an example of a male child with an ACE score of 6 has a 4,600 times more likelihood of becoming an intravenous drug user than a male child with a ACE score of 0. So when you think about the use of drugs, thinking about what happened to that person, remember, that's where we're going to get into that with Dr. Sandra Bloom had coined that term. And Oprah Winfrey and Bessel van der Kolk just wrote that book not too long ago about what happened. So Google the ACE score test. We encourage you to take this test and think about how the people you serve might answer. Many programs are having their people they serve and their family members do the ACE score and do it with the clinical staff, please. So next slide, please. And know that it also impairs worker performance. Trauma can destroy lives for a lifetime, or we can work as hard as we can to support the people we serve. So has this been repeated? Yes, it was repeated in Canada. They found very similar types. Over 10,000 people were involved in their kind of Canadian ACE study. And now it's been repeated in other places too. And as I said, it's continuing and ongoing even in our own country with Kaiser Permanente. So that gets to what are we going to do? Trauma-informed care systems. So what are some of those key principles? Like we talked about yesterday, it's informed by the research. There's evidence of effective practice, and we're going to do everything we can to avoid any type of re-traumatization. So next slide, we're actually moving from what we call controlling practices, rule-based practices, to collaborative practices, from kind of standardized systems, approaches with the people we serve, like points and levels, to really individualized approaches. We're going to take out the cat hair. And so to the next slide then, what do they look like? We're going to think about and ask each of you, as you go back to your programs and the next week and the next weeks to come, think about your environment, think about your practice, and think about the policies you have. So, and this gets exactly to Brenna's question yesterday about what to do. So let's go to the environmental inventory. A very simple thing we can do is make little changes to our environment. SCO, some of them are big changes. SCO in New York is a program, and they had their staff office with glass everywhere in a circular place in the middle of the day room. So the staff could sit in the office and look out around everybody. They took the whole office down, took the walls down. They have a little office now off to the side where they can keep files and different things. Think about a light. How much light can you get? What are you doing in the courtyard? Get some donations for this. One program in New York put up noise reduction panels throughout the entire hospital. It was actually a children's hospital, child and adolescent hospital. So thinking what you can do. And look at this, inviting and welcoming messages. Terry Children's Center, actually in Delaware, they have, if you go into any of the units, next to each, they have individual bedrooms for the youth, and next to each door is a big bulletin board, and they have a picture of the youth. They have his or her or their interests, and what they like to do, and their artwork and different things. It's just like it's a welcoming type of stuff. In Arizona, they had in one residential program, they had on the office door, there's a big sign that said, "Don't come in the office without permission." And they changed that to, "We're here for you." And in fact, Kathy Fuentes, who used to work in one of your programs, one of the first things she did is she took down the sign of her children's unit on the outside of the door that said, visiting hours 6 to 8. And she put "families welcome anytime." So next slide, please. And then also just think about kind of some small things in terms of what the literature says. Encouraging signage. People prefer views of nature and noise. So there is this literature out there about how we can make our environment softer and kinder. Went to a hospital in Kentucky, and it was gray cinder block on the outside and gray cinder block on the inside. And basically what they did is they partnered with a community college art department. The staff came in and worked with the people served, and they painted all of the gray inside different pastel colors. And then they painted pictures of nature, and they made beautiful quotes throughout. I mean, it was paint and a partnership, and you walk in there and you really feel like, oh my goodness, this is so nice. And so the other piece, keep going. Next one, that one, right? Okay. Watch for pink. Okay, pause on the pink, as they said, that there's some contradictory findings about pink. But blue calms and lower blood pressure. Green reduces central nervous system activity. And in fact, if you ask some Reiki experts, they'll say that blue is what you should wear, the color blue, when you're feeling unloved. You know, that blue is the color of love. So look at those kinds of things. And then let's have you, in the next slide, conduct your own environmental inventory. You know, what's trauma informed and what's not trauma informed. Just look at this slide and think about your program. How can you improve that? We worked at the New York City Health and Hospital Corporation, and we worked in their emergency rooms throughout the city. And they made a commitment to make it more comfortable. They tried to move to individual pods. They went to nice artwork that depicted nature and soft colors on paint. Each little pod had, of course, Kleenex. It had colorful pillows. It had a sensory basket. So it's like, what is trauma informed and what is not trauma informed? Just simple inventory. Next step, please. A while back at Franciscan Children's, similar to what I talked about in another program, they had a nurses station, and they changed that to a relaxation station. So what can you do to go back and do an environmental inventory to support this trauma-informed, this welcoming space for the people you serve? And then conduct a practice inventory. And this is, to me, one of the most important things that we can do. Not just you know about the recognition of high prevalence of trauma, everybody does. Maintenance, housekeeping, security, everybody understands that we have clinical staff who are sophisticated and they can assess for the trauma histories, and they share the basic information about what are the triggers for the different people you serve with all the staff who are working with those people, so they understand, is this person triggered by large men when they're upset? Are they triggered by noise? Are they triggered by tight clothes? Are they triggered because they're being rushed? What is it? So that you can incorporate that into what we're calling safety plans, which we'll talk about more tomorrow. And then this bottom one under trauma-informed care, what's trauma-informed? Their recognition of culture and practices that are re-traumatizing. And that's the inventory we want you to take. Emily Werner, who was kind of the foundational researcher in Hawaii, she actually started on resiliency and increasing a focus on strength-based approaches, is saying the most important thing we can do is to support each person's resiliency and their strength-based approaches. So there's programs now throughout the country that one of the first things they do is find out what the people they serve love. Do they like to paint? Do they like to play basketball? Do they like to listen to music? What is it that they like to do, so that we can promote those strengths about it? Bessel van der Kolk, as we've talked about multiple times, he increases practices wherever he works or that he consults to that promotes self-control. You know, just meditation. You breathe in, you breathe out, you breathe in. That promotes self-control. Tai Chi, yoga. Move, if you can, from any kind of focus on just behavior management, even the term behavior management, at least move to behavioral and emotional support. That's what we're looking for. And slowly replace points and levels. Slowly, don't take away things from staff until we've replaced it with other things, but begin to replace that with things that are far more individualized and strength-based. I was in another program in Delaware, and they were giving me a tour of the program. And this is for young children. They were like under the age of 11, and they had like little cars that could go up on the wall. And everybody, that was their points that they had made. And then but almost all of the cars were below like half. So none of the kids had really made any of their points. They were at school at the time the kids were, and they could move them with Velcro. And so I was the last one out. And so I immediately went to that wall and I moved every single little car to the very top. So at least when the children got back, they would think for a minute that they had made all their points. So think about those. Next one, please. Oh, wait, I think you already did it. Sorry. Okay. So this is, I think, maybe one of the most important ones too, this whole trauma-informed. What are we doing in this area? in some programs now to really get that sense of support and collaboration and to minimize the fact that we're the controllers. They have a bulletin board that welcomes, one of the bulletin boards that welcomes people who are served into their unit. They actually have pictures of the different staff. Next to their pictures, they show what did the staff like to do. So when they have a new person that comes onto the unit, they'll say, oh, you'll be working with this staff and this staff. Is there anything up there that you like to do? And somebody will say, oh yeah, I like to fish. Oh, you're going to really like Hank then because he's a big fisher person, so we're getting that connection versus the control, and we're different. And it was very interesting because I went to a program in Nebraska, and when we went in, the adult client said, in this hospital came up immediately. Here's a guest coming in and saying, they won't let me have my music. They won't let me have my music. They won't let me have my music. And we asked about it, and they said, well, she always like tears out her AirPods, and she like throws them or it tears them away. So she just can't have it because she can't. She likes her music, but she doesn't know how to take care of it. But I'd just been to a program in Pennsylvania, and it was the maintenance man who came up with this idea. There was a person with developmental disabilities who loved to listen to the radio, but he also liked to take the radio apart, and he also liked to throw things, and so he could never keep the radio. So the maintenance man came up with this little wire mesh that the only thing he could do was turn on the radio, turn it off the radio. He couldn't destroy it, so he could have his music. So think about what are their limitations, but they still need their comforts and support. There was a program, again in Nebraska, and that you could earn a spa night. You earned a spa night, and the young woman with the most restraints and the worst history of trauma had been there for like 3 months and never once earned a spa night. Who deserved the spa night? So why do we have to earn that? So really thinking about this, even with programs such as PBIS, that was not developed, by the way, for residential programs, but they use it. And so in a program in New York, actually in Rochester, New York, they used PBIS. And if you earned enough bucks or PBIS bucks, you actually got to have one-on-one time with the staff. So who wasn't earning it? Those who didn't have the ability to do it. So think about your practice inventory and what you're doing and what you can do to increase your focus on trauma-informed care. Next slide, please. So look at what they did. Look what they did. They took away the seclusion room and made it a sensory and a playroom. And then continuing on your practice inventory, which of course is one of my favorite things that what we can all do is understand, and all staff understand, that trauma has meaning. Don't take it personally. Take a break if you're taking it personally. I mentioned yesterday House of Good Shepherd in New York, where they debrief through a trauma lens. They make sure they always address the trauma history in their debriefing of any kind of incident. Think about consumers as center of their treatment. At a Connecticut hospital, the staff start every morning, 2 or 3 of the staff, including the therapist, including the head of the unit, they all meet with each individual person served, and they start out their morning by saying, how can we best support you today? So they're beginning the day asking that. And then, of course, really continue to focus on education and transparent systems. Okay, and watch your language. Okay, so the last one on practice inventory, we did environmental inventory. Now we did practice inventory. All of these are important. There's a number of programs that have implemented going around and shaking hands with each of the persons served when they come on duty, and when they're off, when they're going to leave, they shake hands again. And when you shake hands, and if you have somebody you're sitting next to, try to maybe shake their hand. Like they say that this part of your hand, where you can actually then feel the pulse, it actually connects to your heart. You're looking at the person in the eye, you're giving them your attention, you're checking in with them. When you're leaving, you're saying, hey, I won't be here tomorrow, but you know who's here, Matilda's here, and she loves to play that game you like to play. So really thinking about that. I remember when my father was having some serious physical issues, and he was in an assisted living, and it was a very busy place. And there's this one staff who always, even if she was coming down the hall, his door would always be open, and she'd run in there and give him a fist bump. That fist bump meant more to him. What can you do? And saying this, it's a trauma-informed approach. In Allegiant Hospitals, which has residential and hospital programs, and they have really worked there in Nebraska and Iowa, and they had really worked on preventing and reducing restraint and seclusion, had been quite successful with it. And I went on this one unit and was talking to interviewing the person served on the unit, and asked, different questions about how they were treated, what's going on. To a person, the person served said, staff will drop anything if you tell them you have a need. So thinking about that, and how do you line up with all of these that are trauma informed versus what's not trauma informed? So the third area, that's your practice inventory. The third area is just improve the overall social environment. And here we have Director of First Impressions. That happened in New Zealand when actually Kevin was visiting New Zealand with Janice, and they walked into a hospital, and there was this person that, made you feel so welcome. And, like you were the most important person around. And her title was Director of First Impressions. Now I know there's some actually like food places here, restaurants that actually use that term now too. I interviewed some families in a residential program and in New York State, and to a person almost, when the family person said the family peer partner had them at hello. The same thing that Jerry Maguire, they had them at hello. So what can you do just on this to really support the first impressions in people coming into your program? Next slide, please. So next slide. Oops, I guess we missed one of them. You are healers, you're self-soothers, you promote self-regulation, voice, and choice. And so just a few things about the trauma assessment. Next slide. Is that these are some slides. You're going to have these slides that can provide you with key areas to ensure. So it's kind of like we were looking at what's trauma-informed, what's not trauma-informed. Look at the way you do trauma assessments now. Look at some of these slides and see if, in fact, you are incorporating this information into your slides. Of course, we want trained clinicians to be doing those trauma assessments, and again, sharing that. So do you include past abuse? What do you acute type? Do you address age? Do you address who did things? These are just some of the minimum components that you want to address. And then getting back to the next slide is, which we keep saying, it's really, again, from Dr. Sandra Bloom. She was the grandmother of trauma-informed care, and she coined the term, what happened to you? We want to know what happened, not necessarily what's wrong with you. We want to know what happened. And we want to at least do some sort of a trauma assessment very soon after, upon admission, or very soon. And that importance of course, what, had you at hello, that therapeutic engagement can't be stressed enough. And then this next slide is actually one that these are just some key principles to make sure that you address. But the next slide, please. This is relevant for all of us. Do you know of the children, the adolescents, the adults you serve, whether it be in schools, hospitals, residential, community programs? Do they have any of these symptoms, or do they have any of these behaviors? So it's for all of us to know, wow, okay, this is likely trauma related. So this is, I feel like, an important slide to kind of mark, because it helps us remember what this is all about. So if you are, next slide, if you are a leader or you're a clinical staff, you want to make sure that your treatment focus is on safety, stabilization, and self-management. These are three areas that you want to address, particularly skill development, cognitive behavioral approaches, and making sure that people understand how their trauma is going to impact their health and their need for addressing their health prevention. So next slide. Trauma information is not enough. It's like a lot and it's going to help us to get there and create these environments. But we really want to make sure that we, as Emily Warner talks about in her research, and moving away from controlling, we got to move to collaborating, we got to move to enhancing people. And so we want to always focus on positive and protective factors too. As I shared the example of the bulletin board with staff and what they're interested in. So like as soon as the person you serve walks in that very first time, we begin to find out what they like to do. And we want to ensure that we create this rhythm of inquiry, compassionate inquiry. Many of you have received training from the wonderful Dr. Janina Fisher, and she talks a lot about that compassionate inquiry, that we use calming questions, and that we really support the people we're serving with that calmness and that strength-based approach. So trauma-informed care, again, is not enough. We want to really enhance that use of practices they can take home, from meditation, yoga, Tai Chi, even it's chair yoga, stretching, that it, you've seen this on Instagram and, is that there's so much that we can do to help people to kind of bring in and self-regulate, bring in and calm that nervous systems. So we're focusing a lot on those skills of self-regulation. And moving to the next slide, and some of you know Lori Leicht, who was focused, who was mentioned there. Some of you have been to her training, but we want to appreciate these high rates of trauma. We want to understand the characteristics of trauma-informed care and how this differs from care that is not trauma-informed. We want to find the strengths and the protective factors, and we want to link it, which we'll cover in the fourth session, to these crisis plans, soothing plans, and to sensory pieces. And we really want to support that skill development and neuropsychoeducation and training for all staff on trauma-informed care. And in fact, I want to leave you with a story of 3 different programs. These happen to be residential. One was a hospital and 2 were residential. But there was a hospital program where they had an indoor pool. It was an upstate northern country, and so not in Massachusetts. And they had a young girl, 5 years old at the time, who came into the program and into the hospital, and she had a terrible history of restraint. This was a state hospital, and she had been at a local hospital, psychiatric hospital, before she came, where she was restrained all the time. So history of restraint, history of abuse. But they asked, what do you love to do? And she shared, I love to swim. They have a swimming pool. She had the highest rates of restraint in that whole hospital. And she had been there for over 4 months and have not once been swimming, because you're not allowed to go swimming if you are a danger to self or others, and you have to be free of a danger for 48 hours or something. And so there was a sense, here's a girl who needed this swimming, but they couldn't find their way because of this standardized rule. There was another program. This one was in Arizona, where it's very hot, 110 degrees in the summer. They had a pool, outdoor pool on campus. And there was a young man who was swimming. He was an adolescent. And of course, what adolescent boys or girls can do, but he actually got too rowdy. So he got called out of the pool. And when you're rowdy in the pool, you miss swimming for 3 days. And so he couldn't go for 3 days. So what do you think happened during those 3 days? Because he wanted to be outside swimming and having fun. So for 3 days, he missed swimming. He kept having escalation problems. He couldn't self-regulate, problems. He ended up not being able to swim for a month. because he kept missing it. So does that make sense? And then the third program was a program where they took the youth to the YMCA to swim. And so this one young man, not that it's always young man, but it was one young man, went to the YMCA, wouldn't get out when the lifeguard said, okay, we got to clear the pool for what adult lap swim or something. He wouldn't get out. And the lifeguard had a challenge and the staff had a challenge, but they finally got him out, but it caused some disruption. So the staff called back to the program and said, is one of these two staff on? Because they were the favorite staff of this particular young man. So they met the van when this one staff met the van when they came back from the Y, and the staff immediately started to take a walk with that young man. And they walked down the block and up the block and around, and they debriefed the whole situation. And the young man went back. He apologized to the other youth. He apologized to the staff member who was there. And then they announced they're going back to the Y now to go swimming. And who wants to go with them? So they took this youth and other youth back to the Y. He apologized to the lifeguard, and they practiced and practiced getting in and getting out and getting in and getting out. Because if you look at, like, say, the educational research, people learn better when they're in a good place, when they're feeling good. So who learned and who really was more helped in those three situations? So think about your own program and what was more trauma sensitive and what was more likely to help that person learn self-regulation. Thank you. That was a lot of talking, and I hope it was helpful, and really appreciate it. And we're going to move now to Kevin with the next slide. People can go back to this. Oh, and there's lots of references here too, if people want to use them. So you can just go through the references, resources, and people can go back to those and pick those out if they'd like to. Thank you, Dana, for all that, what you're doing. And we'll move to Kevin with risk factors.
Thanks, Beth. So now we're going to move to a module called seclusion restraint risk factors, which of course are anything that creates a higher risk for conflict, escalation, leading to violence in our inpatient, residential, and other types of healthcare settings like that. So the goals are to become familiar with the concept of risk and risk assessment, understand the common models used to explain how we predict violence, and understand the physical and emotional risk factors when we actually do put hands on people. Next slide. So we're going to talk about aggression and violence risk and medical physical risk, which is just at the end and not very many slides, but important for everybody to know. Next slide. So the first concept, which is really important, is to understand that when we start talking about predicting risk or identifying risk factors, that the whole concept of risk is contextual. And I guess the best way to explain it is this. If you go downstairs or in your kitchen at home, there's going to be all kinds of stuff there, including knives, scissors, other regular kitchen equipment. And we don't think anything about that. But if you went on your unit tomorrow and you saw a big, huge carving knife in the middle of the day room, you would probably get a little uneasy about that and ask somebody, what is that doing there? And that's because the risk of having a large carving knife on an inpatient unit is quite different than in your own kitchen at home. So it's important to understand that when we talk about risk, that we look in the environment and what is going on in that environment. Next slide. Risk regarding seclusion restraint is every single time you put hands on a child or an adult in your care, you run the risk of being injured or having the client get injured, both physical and emotional risk and injury. And you also have another risk factor, which is what everybody else standing around and watching just learned, quote unquote, from this event. I can't tell you how many times I've done rounds after a seclusion or restraint event, which often can look extremely violent, and found that everybody standing around, they missed the first part. So they have no idea what just happened. And all they saw was that a bunch of staff grabbed a patient and made them do something they didn't want to do. And it was done with violence. What if we saw something like that on the street, we would think that was an assault. So it's really, really important to always remember our observers, because they may or may not say anything, but they also may or may not be extremely confused and quite fearful about what happened because they don't know the context. Risk assessment is not about predictions. We're terrible at predicting risks. It's a little teeny bit better than flipping a coin. Risk assessment is actually about providing an opportunity to have a discussion with more than one person. And it also needs to include clinical issues having to do with the patient, environmental risk factors that have to do with your own environment of care and where you work, and the competencies that the staff have in your unit. Risk assessment also includes looking at and identifying conditions that may increase or decrease the likelihood of a problem occurring. So for instance, a lot of noise in a unit. I know I've always hated when we've had to do renovations on units because of the noise factor and the fact that we've got strangers on the unit and they've got equipment and supplies that can be grabbed and used as weapons. I've always been incredibly uncomfortable with that because anytime you do renovation, you're increasing a risk factor. We also really want to look at behaviors. Institutional violence is any kind of behavior in a health, I'm just going to talk healthcare right now, in a healthcare organization that involves verbal threats and or physical or sexual assault in what is supposed to be a safe environment. And this is a very serious problem. And it also creates situations for our staff where they are at very high risk, much higher risk than if they worked at McDonald's. And that became a real issue through COVID because I'll never forget, I was running programs in the Northeast and I got a text from one of my staff because we were having such such difficulty filling positions for our mental health techs and for our peer support staff. We were like had vacancies everywhere. And she sent me a picture of a McDonald's sign that said hiring $21 an hour. We were paying $16 an hour. How in the world are we going to compete when the people that we're hiring not only have a very difficult job, but are now at risk to possibly be getting punched? So we need to constantly remember that. And that's another reason why it's so important to make our environments of care as safe as possible, because staff won't stay working for you if they feel like they're going to get hurt. Effects of violence in our healthcare institutions include physical, emotional injury, property destruction, expenses, lawsuits, increased restrictiveness, because often when something bad happens, the first thing that the leaders do is create another rule. And morale issues. Next slide. So there are 3 violence models over the years. The most common and still around is blame the patient. And you'll hear that when you hear staff talk about, well, the patients never used to be this violent. And the reason we have to use seclusion and restraint is because we have the most violent children in the whole state, or we have the most violent adults. I just was talking to a CEO in a hospital and he said to me, we have the worst patients in this entire state because everybody sends us the people they can't manage. Well, that's the blame the patient model. And interestingly enough, if you look back at the literature, which of course we really did a huge literature search and have continued to do that throughout the years on violence, what we found back in the 30s, 40s, 50s, 60s was that almost all the research on violence was a researcher or two going into a facility, a healthcare facility, and asking the leaders to give them all the medical records of the patients who had been violent over the last year or 6 months or whatever their time frame was. And those researchers would sit in a room and they would review these medical records, and they would identify all the demographic factors about the patients that had been violent. And after they were done with their research, they'd come out and they'd tell the CEO, I'll just make an example, the most violent, your highest risk, most violent people in this facility are in their early 30s. They are people that have come through often the foster care or juvenile justice system in either this state or another state. They have substance use disorders, and they basically have had legal involvement somewhere along the line. And so that facility would go away thinking, oh my gosh, those are the patients that we have to be really careful about, and they treat them differently, and sometimes they refuse admission. And that went on for years and years and years and years and years, until some other researchers put all that research together and found out that there was no type of patient that was violent. It was very specific to the hospital. It was specific to the unit. It was specific to the staff. It was specific to the way the units were and the hospital was laid out. So again, that concept of it's all the patient's fault, and if patients weren't violent, we wouldn't have any trouble, is still alive and well, but it is not correct. The next violence model was the belief, and still is around also, is that when you take someone and put them in a facility that's institutional, involuntary, and removes their rights and locks them in, that alone are the triggers that cause regular people to get very, very angry. And as we've spoken about already, when you remove the ability for someone to meet their own needs, whether that's going to a computer, using their cell phone, taking a shower, eating, seconds and thirds at breakfast, when you remove that ability and you take it away, people get angry. And I've always thought and said that if all of us were in the same place and there was a natural disaster and we all got locked down for a week, someone would get in a fist fight. And, most of us don't have serious mental illness or serious emotional disturbance, but somebody would get in an argument just because we're human. So what has come to be, and what we now understand about violence, is that violence is a complex issue, and it is an event of violence comes about through a combination of what is going on in that context, which we talked about before, risk and the context. So it's the patient and patient issues, it's the staff and staff issues, and it's the environment of care. And that is the most useful in understanding violence and violence risk factors in our settings. Next slide. Situational risk factors are those negative or sometimes neutral features of a setting where violence takes place. These factors include the setting's normal violence levels. Does this stuff happen all the time, or is it very rare? The management structures, leadership styles, policies, the physical environment, the noise level, the temperature control, signage, colors, quality and skills of staff, quality and skills of supervisors, quality of life factors, and what treatment interventions are in place in that environment, that unit, or that hospital. Next slide. So literature on causes of violence. I'm just going to go through some of the really important literature. Some of it's very important because it was only done once and it could never be done again because of rules and regulations we now have on research that did not exist, for instance, back in 1973, when David Rosenhan, who was a psychologist, did a research study titled On Being Sane in Insane Places, after which he and his colleagues were quite criticized. And this research, because of the methods that were used, was then ignored afterwards, even though the learning of this research project is critically important. So what David Rosenhan did was he identified 8 regular people and he called them pseudo patients, fake patients. And he got them to agree to be admitted to 12 different hospitals. Next slide. So all the facilities were different. Some were large, some were small, some were public, some were private, and they were in different United States, different states in the United States. All the participants, the people that were pretending to be patients, went to the admission door and said they were hearing voices. And that's all they said. They didn't say very much at all after that. And once they were admitted, they then reported to the staff that the voices were gone, and they just acted like they had on the outside as regular people. Next slide. So during their admissions, as they had been directed, these fake patients, they took a bunch of notes on what was going on in the unit and how the staff were responding. And this is what they recorded, that their normal behaviors of note-taking and other patients, anxiety and boredom, were seen and documented as pathology and symptoms of mental illness per the medical records. Real patients on the units whose behaviors were observed the behaviors were often misinterpreted by staff. Next slide. Often a patient would become violent related to mistreatment by staff, but rarely would the nurse inquire as to what had happened and would just assume that it was the mental illness that caused that person to become violent. And when we say mistreatment, we're not talking about abuse. We're talking about things like disrespect, shame, humiliation, enforcing rules, power issues. Never were the staff noted to assume that either they or another environmental factor had anything to do with the way the patients were responding. Next slide. Elaine Morrison, she did a very famous study. She's a nurse, was a nurse researcher in 1989. This was also a study where she was quite criticized, and after the fact, she tried to take this study back, but it was already been published. She went into 2 units and spent 6 months there hanging out. So she actually was doing what's called qualitative research, where it's kind of ethnographic research, which is what anthropologists do when they go in to study a new civilization that they want to learn about. They hang out until nobody pays any attention to them anymore. They don't get involved in anything. They just are kind of like flies on the wall, and they watch the population that they're trying to learn about. So she did that on these 2 psychiatric units for 6 months. And what she found was a lack of individualized care, rigid use of the medical model, highly routinized staff tasks that included giving medication, making sure people went to bed and woke up on time, and escorting people around for appointments. Next slide. The unit norms included the need for physical restraint. So the staff all believed that physical restraint was completely normal and needed to be used. And they also had this funny message that they gave to people. It wasn't really verbal. It was kind of an unwritten message when they were explaining to people on admission that they had to behave in certain ways or they might get restrained. And the inference was, it's not you we don't trust, but think about what that message says to a patient. What do you mean it's not that you don't trust me? Is there other people here you don't trust? Is this not safe? Is someone else here that's untrustworthy? So it was kind of a very odd environment. She also found that roles for the nursing assistants included enforcing, policing, supermanning, and putting on a show. Those were the words that she put the staff behavior in. And that new staff who came on board through orientation were kind of coerced into compliance to these roles and were basically told verbally and non-verbally that if they didn't conform to what all the other staff were doing, that they would not be helped if they got themselves in a pickle. She also noted that staff roles were described as the process of carrying out the rules aimed to control patient behaviors. Staff were valued according to how good they were at that. Rules that denied people's access to food, TV, phone, belongings often ended in violence, and that when administrators came through, staff hid that behavior from them. Next slide. Dr. Oken looked at a variety of United States psychiatric hospitals in one state alone for 5 months. And interestingly enough, in 1985, that one state was Massachusetts. He found that the use of seclusion restraint varied significantly from hospital to hospital, even though the populations served were the same, adult general population patients. And he couldn't explain the differences in the use of seclusion restraint by patient demographics or pre-admission behavior. And he concluded that the factors related to the use of seclusion and restraint in those 5 hospitals were based on those 5 hospital practices, policies, and conditions that were all under the power of the administrators to change or not. Next slide. Petty, Moore, and Summers performed another review in 2001. They found that the research on the use of seclusion and restraint was inconclusive, and that it all focused on the patient as the problem. They also found that the medical record jargon that, Beth got hostile and violent and was restrained did not tell them anything. They did not describe what happened. It didn't describe what led up to the event. It didn't describe the triggers, and that aggressive in the medical record could mean anything from cursing to spitting to hitting. And injuries, Beth was injured, could be being pushed or pinched up to fractures. Again, non-specific language that didn't help anybody really understand what had happened. They found that a need for more for better assessments on the events leading up to the use of seclusion and restraint, and that it needed to be more than Beth was put in restraint to keep her safe. That didn't tell us anything. They also found a need for an attitude change in staff that would have to be led by leaders that valued and learned from the consumer's experience, meaning you have the dialogue with the patients to find out what they liked and what they didn't like about that environment. And they also the need to understand why staff reported these events very differently than the patients did. Next slide. Moore and Anderson in another study found that the 4 most common reasons used to explain and support the use of seclusion and restraint did not meet the criteria that was mandated by the federal regulations about seclusion and restraint, and that the real reasons that restraint and seclusion were being used were old staff attitudes, patients disrupting the environment but not reaching the threshold of imminent danger, refusal to obey orders, and preventing property damage. Next slide. Another study in a 2-month time frame in a child facility found that the causal factors to violence were staff verbal directions, staff redirections, and limit setting. Service user ages, history with DJJ, diagnosis, and gender were not significant in this study. Next slide. In this study, this was a really important study in 2005 that was done in South Carolina, I believe. And it was, it looked at the perceptions of patients in inpatient settings. And what those patients described was they coined this phrase, the patient's sanctuary harm. And they also talked about feeling a constant threat of violence from their colleagues and staff, and idiosyncratic use of the rules from shift to shift and different staff to different staff. Staff not knowing them as individuals and being treated just like everybody was treated the same. Unfair treatment practices. Remember what Beth talked about. People do not do well when they feel like something is unfair or that they're being treated differently, and being embarrassed or disrespected in the treatment setting. Next slide. O'Brien and Cole did a study on an acute psychiatric intensive care unit in Australia back in the 2000s, and they found that violence appeared to be environmentally driven by rules such as forced compliance, making your bed, standing in line, being quiet, taking your meds. and had nothing to do with the diagnosis of why the person was there in the first place. They also found that violence management relied on control and containment, that there was no prevention in place. So when we start to talk about assessing risk, we want to look at risk factors for conflict and violence. And we need to look at this together with our colleagues, because together we have a much better chance to identify risk factors than if we're doing that by ourselves. Next slide. The most important and valid risk factor for violent behavior is previous violence that that person perpetrated that we can validate as to have happened. So that kind of violence is physical or sexual aggression, previous history of being in seclusion and restraint with a caveat, and previous legal charges like assault with the caveat. Now remember, people, the Irvo Otieno, one of the young men that died in the Assumptions PowerPoint, he was arrested for assault on a police officer. However, when they went back and looked at the body cam, all he did was wave them off and then push them off, and that was considered assault. So whenever we see charges like assault, we need to remember that we weren't there, and we need to take that with a grain of salt. The same thing when someone comes into us with a history of violence. We need to make sure, because we have no idea really what happened, and we need to ask the patient what happened, because a lot of the times we label patients violent when we place them in situations where possibly we might have become violent also. We also need to look at events related to hospitalization that are common triggers to aggression and violence. Hospital policies, especially when they're implemented unfairly or inconsistently. And I know you guys probably all work shift. I work shift work. I'm a nurse. I'm a psychiatric nurse. I've worked shift work for years. And I always remember coming in on the evening shift and knowing that the shift before had some staff on it that would let people pretty much do anything they wanted, including get in other people's faces, wander in and out of people's rooms, which can be very dangerous for patients because patients get really angry when other people come in their rooms and maybe take stuff. And so we'd always have to go around and kind of reorient everybody to the safety rules of that unit. And I also remember going in to units on my shift and having Nurse Ratchet have been there the whole shift before, and that everybody was super tense and upset and angry because Nurse Ratchet was one for the rules and nobody could do anything. So we need to remember that patients, they live there and we come in and out, and they're supposed to remember who's who acts how, who enforces which rules, who doesn't. And that gets very complicated and difficult for patients. So we need to remember that that's extra stress. We also need to remember that when people feel like they've been treated unfairly, they do not tend to like that, whether they have a mental illness or not. We also need to remember when we put people in lines, they tend to not like that either. It's a reason why the psychologists that developed those Disneyland curvy metal lines where you stand in line for a ride did that. Those are psychological. So you can't see how long the line is. And so you can actually people watch while you're standing in line, which helps you not get as aggravated if you have to stand there a long time. Mandatory strip searches and automatic disrobing is another real trigger for people. Next slide. Practices of shame or humiliate. Dr. Garbarino and Gilligan really pointed this out when they did their research. Controlling and restrictive environments with unfair rules. It increased assaults. Authoritative systems where the staff are afraid of supervisors and don't have a lot of voice can create some real problems for patients and staff. Next slide. Crowding, poor staff training and conflict prevention and management, younger staff with less experience, nothing to do, lack of peer support. Next slide. All the preceding environmental stressors or triggers are completely preventable. if we identify them, we talk about them, and we have the power to either bring them to supervisors or change them. We really need to stop believing that inpatient conflicts are due to magical factors or are all the patient's fault, because they're not. And we can do a lot to prevent these things from happening. Next slide. We can skip this. Next slide. Next slide. Okay. Assessing risk for violence, know the potential contributors to violence, including the person's individual history and unique triggers. Use your assessment tools on admission and drill down on whether that admission history is accurate. And then constantly do a review of your environmental risk factors to try and minimize those triggers. And if you can't minimize them, explain them to patients. And then this next section is the actual dangers of seclusion and restraint, especially restraint in takedowns, physical holds, and mechanical. Anytime, again, we put hands on, we have potential problems with airway obstruction, injuries to all involved, exacerbation of unknown or sometimes known medical disorders like asthma or abdominal obesity or cardiac problems that we don't know about, and that these may occur in combination. Next slide. This is one of the most dangerous situations to occur in restraint. It's called positional asphyxia, and it's when someone's body gets placed or they place it in a position that interferes with respiration, with the ability to take in air and exhale air. Prone positioning. Anytime we place someone face down, there's a whole bunch of muscles in the human body that make us breathe. And those muscles go from the top of our head to basically our groin area. And so when any pressure is placed anywhere between our head and our groin, that can cause some serious problems in breathing. So anybody that has more abdominal girth, who's panicked, who has a small build, who has a history of asthma, who has a common cold at the time, putting them face down is a huge problem. Flexing the head into the chest is a huge problem. Basket holds, which I just heard very short time ago, are still being used in some programs, which is where you grab the child from behind and pull their arms around and as such put pressure on our chest. Covering a person's face with a towel or other object. Another reason prone positioning is so dangerous is that you can't see the person's face anymore, and it's the first thing that will tell you they're in trouble. So but in many states, not most, many states have outlawed prone positioning or mandated a special order for prone positioning if in case there's some reason why it's more safe for that particular person to be prone or on their side. Another issue about prone positioning is often if we have to take someone down, we take them down face first because it's safer. But what that means is once we get them down to the bed or the floor or the cot or whatever, we need to remember the 3-second rule, which is to turn them on their side or on their back so we can see their face again. I can't tell you how many videos I've had to watch where a person was face down, bunch of people on top of them, and they said multiple times, "I can't breathe." And then they died. There's a myth that if you can talk, you can breathe. It's a myth. So please know that. Next slide. Next slide. Other medical risk factors, history of recent surgery, any kind of spinal or back problems, respiratory problems of all types and shapes. That's why it's important to note if someone has a really bad cold or asthma, especially emphysema, when they come into your facility, and note that could be a problem if you get into a struggle. Unknown cardiac conditions, which many times nobody even knows they have cardiac arrhythmia or something else that's often genetic, obesity, pregnancy, or other conditions of enlarged abdomens. Next slide. Other medical risk factors, when you have what looks like an assault, you've got two people struggling, that causes something that's called a catecholamine rush. And that's when your body, your amygdala has gone off, your smoke detector has triggered, and your body basically releases a ton of hormones called catecholamines. And that's adrenaline, norepinephrine, dopamine, serotonin, and cortisol. And those together cause all of our vital signs to go sky high, causes us to go into the fight or flight or freeze response. And if you have a cardiac arrhythmia, that can cause sudden death. So again, just the efforts put into the struggle of putting hands on can be extremely dangerous, especially because we don't know that this person has that cardiac problem. Next slide. Best way to avoid injury or death, avoid using hands-on restraint in the first place. We will never know all the risk factors a person has coming in the door. Next slide. Okay, we're now going to go on a break. It's 10:45, so we will see you back at 11 for our last module. Thank you very much, and please get up and stretch.
Yes, stretch and move and jump up and down. Get that internal nervous system regulating, everybody. Great job, Kevin. Thank you.
All right, whenever you're ready, Kevin.
Okay. Welcome back from break. Hope you guys got a chance to walk around or stretch or something. What we're going to talk about now is the third core strategy, workforce development. The goals are to understand the importance of elevating the visibility of the use of seclusion and restraint, describe the use of witnessing, or also called elevating the visibility, describe the use of witnessing as an important and effective intervention, identify specific changes in the roles and responsibilities of staff at all levels of the organization in order to make this culture change process effective, and understand how to use human resources and staff development systems to help develop our workforces. So when it came to workforce development as the third core strategy in this evidence-based practice model, we realized really early on that what we couldn't do was continue to approach seclusion restraint as we always had, which was pretty much like a normal part of our psychiatric mental health inpatient settings. And we realized that a lot went into that. One of it was to more carefully observe what was going on. One was to better document it. In some cases, we needed to change the language that we were using. And we needed to basically be able to report it more timely. What we found when we went into facilities, when we were developing the 6 core strategies, was that often the senior leaders didn't really know much, unless someone got hurt. They really wouldn't pay that much attention or know that much about whether seclusion and restraint was even being used. They would get a report, usually from quality improvement, performance improvement, or risk management every month, every quarter. That was just a bunch of numbers. And it really wasn't drilled down or analyzed very well. And it was completely dehumanized because there were no names on it, obviously. It was just a report of that quarter or that month. And again, it was kind of sanitized. So we realized that that needed to change. So we developed these pieces in workforce development, which includes witnessing or staff oversight of events, human resource activities, and application training guidelines. Next slide. So we're going to go to witnessing. Witnessing in this case refers to organizational changes in the way we look at seclusion and restraint, the oversight of it, the accountability for it, timely communication about it, and a hospital leadership commitment to follow through after every seclusion and restraint event. The goal of witnessing or viewing seclusion and restraint differently is to prevent the use of seclusion and restraint by watching and elevating the visibility of every single event 24 hours a day, 7 days per week. Organizational leadership ensures effective oversight and accountability. And the way they do that in witnessing is by assigning very specific duties and responsibilities to different levels of staff for each event. So I'm going to divide our typical staff in hospitals and residential programs. I know it's different from program to program. A lot of this depends on how large you are. If you're a DJJ program, it's probably the terminology of your staff is going to be different. But let me explain what I'm talking about here in these levels of staff so you can adapt and apply it to your own organization. So the first group of staff we're talking about are the senior executive leaders, what we call the C-suite, what we'd call the administrator of the facility, the hospital, the director of the hospital, or the unit. If you're a unit in a hospital, it would be at the unit level. And these are the people that are 24/7 on call, and they are responsible for what's going on in that particular service all the time. These are the folks that do the budgets, make the policy changes, hire, fire, all those kinds of things. So we're talking about our executive leaders. There's usually at least 2 or 3, and in some larger systems, there's 7, 8, 9, 10. The second level of staff we're talking about here is what I call the on-site supervisor role. Now, that's what we call it in hospitals. It's usually a nurse, a nursing supervisor, and these are the people that work evenings, nights, weekends, and holidays and take the place of the executive staff when the executive staff aren't there. So they're kind of the most senior staff in the facility when the executives aren't there. So in a residential program, that might be a house manager. It could be whatever your organization, whoever's running the place when the day shift isn't there. So I'm going to call it on-site supervisors for evenings, nights, weekends, and holidays. And then last is the direct care staff roles, which is all of us. If you're working that day, you're a direct care staff. Next slide. So in witnessing, in the concept of witnessing, the new on-call executive role is described as this. That person for seclusion and restraint events is on call 24/7. And that means that member of that executive team gets called whenever a seclusion and restraint event happens, whether it's daytime, nighttime, evening, holiday, weekend, whatever. Now they're at home, they're not in the hospital. We recognize that's a big commitment. So sometimes facilities share that role among their executive team. And these are often, different kinds of staff for children and adolescent facilities, DJJ facilities, IDD facilities. But that's what we're talking about. Somebody on the executive team who has a real interest in this work is on call. I was on call in Florida for this for years. Also as a chief nursing officer, I was on call in Delaware when I ran the hospital there for a year and a half. As a CEO, I was on call Bridgewater. I shared that with my George Gensoli, who was the first CEO there. And then I was. So we took those calls anytime someone escalated and had to be either secluded or restrained. And we had the next slide. We had basically a tablet next to our bed, and we would pick up the phone, find out what had happened, ask for specifics, try and find out why the event occurred, what were the antecedents to it happening, what was happening beforehand, what was the source of the conflict, who was the patient, had this ever happened before, is anybody hurt, where's the patient now, where are the staff, and basically just try and get as much information as we possibly could from the unit, and then take those notes and follow up in the morning at that morning meeting. Next slide. So what we would do is we'd always ask who was involved by the staff to check in with them the next day. we always wanted to know if there was any ability to use least restrictive measures, alternatives, options. Did the safety or calming plan get brought out? We also wanted to know, or would find out, what was that person's history of violence? Were they particularly at risk? Did we not know that? Did we know that? Did we even ask the question when they came in? And really the purpose overall was to capture the story of what happened, which is way more than Beth got upset, hit Johnny, and got put in restraint. That's not a story. That's a note. We would also ask, how everybody was doing now. If the person who called was not involved in the event, we'd want to talk to someone who was, and obviously find out what the point of the power struggle was, if there was a power struggle, because that's often how we were able to identify policies and practices that were causing people to get upset. Next slide. So this is an example. Staff called me and said Amber was restrained because she refused to leave the program area and go to bed. Slide. Amber is 17 years old, had experienced much disruption and trauma. She had multiple diagnoses. Her current concerns for us were serious depression and aggression toward others. She'd also come in making some credible reports about sexual abuse by her older brother, but then immediately said she was made it up, although we didn't believe she made it up, but she took it back and said she would not discuss it anymore. She had real trouble following the rules and would often disrupt the unit through a variety of behaviors. That day, she was sitting on a chair. She was drawing on her hand. It was evening. She was asked multiple times to leave the living area because it was past her bedtime. She ignored the staff member. So the staff went and asked another staff to come talk to Amber because she thought she might have better luck. The other staff came over. Amber refused to listen. She wouldn't budge. The new staff person took Amber's arm to try and gently pull her up from the chair, and she escalated and hit the staff member and started screaming. And so both staff restrained her. Next slide. So when I was called, I found, and I bet was pretty new at this program, that the programming was generally kind of punitive in nature. Another story of a kid who was never able to earn any privileges, and she'd been there for 7 months. And because of her behavior, she never got anything going for her. We knew on admission that she loved animals and she loved to work with animals, that she had her own dog walking business for 2 summers. And there was an opportunity in this program to allow her to volunteer at the local animal shelter, but you had to be safe. And since she had never been able to demonstrate safety, she was never allowed to leave the unit. So even though she had a safety plan, it had not been changed in over 3 admissions, even though she regularly engaged in disruptive behaviors and her safety plan obviously was not working very well. And we also found that the staff had been trained, wasn't their fault, that consequences would make her change her behavior. So in other words, punishment, negative consequences, which is what anybody that's had children, that's something that's kind of indoctrinated into parents in some cases. And so they bring that belief, not everybody, but they bring that belief to work. And I can't tell you how many times I've heard a staff member say to me or say to a colleague, yeah, if that was my kid, they wouldn't get away with that. And that's just an example of that mindset, that somehow consequences change behaviors. They don't, by the way. Next slide. Staff also understood that their priority in that program was to make the schedule happen, that they would get in trouble if anybody went outside of the schedule. Staff had not received training or supervision on how to engage with young people, to build trusting relationships, and to basically that they had the power to negotiate and do pretty much whatever they could to avoid putting hands on. So in this case with Amber, it would have been leave her alone. Don't bug her. Just walk away. As long as she's quiet and drawing on her hands, go prompt her a couple times, ask her if she wants some warm milk, ask her if she wants to go watch TV in the day room as long as it's on low volume. Whatever it is, to not make a power struggle out of it. The other thing that was important here was that the licensed clinical social worker, who was kind of the clinical lead and who would be on the unit helping staff make some of these more difficult decisions, we had a vacancy for 5 months. So there's no one providing any kind of help to the direct care staff, many of whom were very young. And so the new staff took direction from the longer term other staff who, had been there for a while and taught them the way it was really done. So it was this whole cluster of things. Next slide. So what we did was we immediately created a training program and a review during every shift change. So we could talk about the program philosophy on trauma-informed care. Staff could understand that rules were not worth getting a broken bone, and that unless it was safety issue, imminent danger issue, that schedules could be changed, rules could be changed, and then brought to the treatment team for discussions. How to use safety and calming plans, how to review those, how to revise them, and how to engage a patient into actually owning that plan. Because if you just write a plan for somebody, they could care less. They're not going to follow it. And that would go for you, me, or kids, whoever. I mean, you've got to get the person to own it. And then perhaps you can then see if it's effective. For staff to focus on doing whatever it takes to avoid restraint or seclusion, and empowering staff to make decisions, and with the understanding that they're going to make poor decisions sometimes, and we're not going to punish anybody. We're going to talk about it. Another example, Sam, this young man, I knew very well, 28-year-old male, had schizoaffective disorder. He constantly ran away and lived on the streets, because most of the time he lived with his mom, who was lovely and exhausted. And this particular time, he was wielding a fake plastic gun in the city of Wilmington, one of the most dangerous, violent cities in the country if you adjust for size. And he almost got shot. He was very, very lucky, because the police officer who noticed the gun realized he knew Sam, and Sam thought he was a rapper. He also used pot a lot. He was off his meds. He didn't have any insight, really, a lot of trauma in his younger years. So he got admitted to the hospital. He was hypomanic on admission because he'd been off his meds. And the hospital had a rule that that people had to attend group on their day 2 of admissions. So he was forced to go to group. And of course, being hypomanic and not sleeping and barely on meds again, and probably anxious, he got up in the group. And of course, 2 staff walked over to him and said, "You can't leave." He said, F you, I'm leaving. He was a pretty big guy. And the 2 staff, who were men, said no and kind of cornered him, and he punched them, and he was restrained. So what we found, sorry, go back, Dana. What we found was that we, first of all, had completely ignored all his admission info, which talked about his inability to concentrate, his mother's report that if ever he started to get upset, do not send men to talk to him. He had serious problems with his dad and his his adoptive dad and his regular dad. And he wasn't on his meds. He was possibly detoxing. And so we basically set him up to go into restraint and seclusion. And we had to do a lot of talking with the staff about that, because as you can see, looking at this in that completely different way that we set him up is a real different way to look at something like that kind of an event. So again, just making the point that that's why we want everybody looking at these incidents and events. Next slide. Another 32-year-old male, Dan, had autism, was on the spectrum, was schizophrenia, was living at his parents, was getting more and more obsessive compulsive, having problems walking through doorways, started to refuse meds. He got kind of aggressive with his parents. He came in the unit. He was not engaged at all. He was very quiet. He didn't bother anybody, but he didn't engage with anyone. And we just ignored him because we had other people that were a lot louder and a lot more scary and difficult. and were not doing well. And so we just kind of ignored them. We also had very little experience with autism. So one day he went up and he punched a nurse 3 times in the face, and no one knew why. And he was restrained. Not only that, all of a sudden, all over his record was unprovoked violence, dangerously violent. He became one of those people that if we hadn't found out what had happened, he would have left our facility being labeled as a high-level violence. The highest level of violence is unprovoked stranger violence. So what we found out, though, was a couple days later, 2 mental health associates told their supervisor that the nurse had been escalating this patient since his admission, had been basically pointing at him when he came to get meds and saying, you need to talk to me. You need to tell me what your name is and what your medications are, or I'm not even going to give them to you, and was really in his face. And that changed the whole picture right there. Not that it was okay for him to hit her. It wasn't. But this guy's in a hospital because he's not doing well. So that was kind of on us. Next slide. So the on-call duty is time intensive, can be assigned to a rotating call list as long as everybody who's on the call list knows what they're doing and wants to do it. Somebody needs to be assigned an overall lead. Depending on the facility, whoever this executive staff is that's on call needs to be given time to perform these duties and maybe needs to hand off some other duties to somebody else. Unless grievous misconduct occurs on the part of staff, no disciplinary action should occur. Needs to result, the executive staff, also this kind of information would result in policy changes. Emerging patterns of behavior on the part of the individual staff or high rates of involvement in incidents also need to be addressed, because as we identified before, there has often been in our history in behavioral health, certain staff that by virtue of their size or their demeanor or whatever, have been kind of labeled as the peacemakers, the people that will go in and fix an escalating problem. And that's not really fair, because all of us should have those competencies, but sometimes it's often young men, it's often large young men staff who kind of get assigned to that role. And so you need to watch out for that, because that also puts them at much higher risk of injury when you're the one person that's constantly responding. Next slide. Okay, so the next level of staff, the on-site staff supervisor, that's the people that are there when the executives are gone. So evenings, weekends, nights, and holidays. So you can call them, we'll just call them senior staff, on-site senior staff. So what you want to have happen here is every single time an event occurs in that unit or in that hospital, that on-site supervisor immediately responds, just like you would in a medical surgical facility with a code blue and a crash cart. So every seclusion restraint event requires an immediate visit by a qualified nursing supervisor or a senior direct care staff who's been there for a while, and they respond to this event like they would a cardiac arrest or a suicide attempt. Next slide. Now we're going to go into direct care staff, which was the third level. And so what I'm going to, this is where our work shifts into the human resource department, some other adjunctive departments like recruiting. So what we want to do here is integrate seclusion and restraint prevention and reduction strategies in our human resource activities. And that will include new hire interview procedures. So before someone even gets hired, how are we going to interview them? And how are we going to figure out if it's a good fit? Job descriptions, which are basically work contracts. And if it's not in the job description, you can't expect someone to do it. Other duties as assigned works a bit, but not very well when it comes to things like seclusion and restraint competencies. Regular competencies, supervision, who is supervising that person and do they know how to supervise. Performance evaluations, which are usually done annually, really should be done more often, but we usually don't have time. And then also new employee orientation or onboarding. Next slide. So in the new hire interview, whoever is doing the new hire interview, and what I've done in a couple places is just do prompt sheets for staff that are doing interviews, because obviously one or two people can't do all the new applicant interviews. So I just do a prompt sheet to make sure the same information was covered. You want to talk about your goals to reduce and prevent the use of seclusion and restraint, that your facility believes that people can recover and can build resiliency skills, that we believe that our role is to A, keep people safe, and B, engage with them so that they will participate in their own treatment process, because that's the only way people learn different ways of being and doing, and how to cope with having what is often a long-term illness like serious mental illness. We want to talk to the applicant about what their past training has been on using seclusion and restraint. What do they believe about it? What is their attitude about it? We're going to want to use behavioral interviewing questions, which means we're going to ask questions that will have a person have to use their judgment. These are the kinds of questions that there's not a right or wrong answer. So this would be a question such as, okay, Beth, you're a mental health counselor and you say you want to come to work here. So what would you do if you saw a young woman sitting in her chair in the day room? Bedtime was 10, it's 10:45. She's refusing to listen to staff and she's just basically ignoring us. What would you do about that? That gives you a chance to see what that applicant, their thinking process, their values. And there's no right or wrong answer, but it will help you make a decision if they will fit in to your milieu. You'll usually know pretty quickly, and you can do 4 or 5 of those questions. It's a really good way. They're called behavioral interview questions. If you have the ability and have peer support staff or family members, you want to use them in many interviews, especially with direct care staff, because they often have an intuitive sense on who might do really well and who might not do so well. Next slide. Job descriptions, we want to insert the expected knowledge and skills. We want to keep it safe, keep it simple. We want to do a few statements that cover both clinical skills and attitude skills. Next slide. So this is an example of job description type inserts. The RN is responsible to be informed and skilled in the safe use of seclusion and restraint, including knowledge of prevention strategies and physical emotional risk factors. Mental health technicians are responsible for understanding and using the least restrictive interventions per program policy and to successfully avoid the use of seclusion and restraint whenever possible. So that makes it pretty clear, kind of the focus of the organization. Competencies, there's a number of competencies that should be mandatory. In many cases, we either assume our staff are competent in these areas or we don't even think about them. So we're talking about therapeutic communication and negotiation skills, de-escalation skills, how to use a risk assessment, trauma-informed interventions like Beth just went over, demonstrations on how to avoid using seclusion and restraint, knowledge about if you have to put hands on, how do you do that as safely as possible, which includes monitoring consistently and safely and the use of safety and calming plans. Next slide. Attitude competencies should be also included. Understand trauma-informed approaches using person-first language, understanding choice as important, and used when you're negotiating with someone who's starting to escalate, minimizing the display of signs of control, and demonstrating kindness, compassion, and respect regardless of how you personally are feeling today. Supervision must be strength-based. We often promote folks that are great clinicians and may or may not should be supervisors. So if you look at the literature on why people leave their jobs, the first reason is being mandated to work double shifts because someone called out sick. The second reason that's almost as highly rated is their supervisor. So supervision must be strength-based, proactive, formal, and informal, not once a year. There should be staff meetings and then individual meetings at least once a month. And the supervisor should be evaluated on their staff's performance. Next slide. Keith Bailey in Tennessee used to do this module, and he always put this in. Nearly every leader has had to tell one or more staff that it is time that they move their gifts and graces to work in other places. Next slide. Performance evaluations. Obviously, we all know what a performance evaluation is, and it's measuring performance and identifying places to improve and calling out exemplary work, and identifying champions. Remember that recognition piece, really important to value exemplary work and to recognize it and reward it. Next slide. And you can do that without money, guys. You can do that with free meal tickets if you have a cafeteria, parking space for a month that's close to the door. I mean, there's just all kinds of things you can do. New employee orientation, cover seclusion and restraint project, your whatever you call it in your facility. Some people have given them names, these projects names. Use 30 minutes to cover this in your onboarding process. A program leader or the hospital director should do this piece. Include a discussion about your policy statement on seclusion and restraint that should have a introduction that talks about why this is important to your organization in terms of vision, values, and why you want to reduce, which should be safety for everybody as the first reason. Include data, where you've been, where you are, and where you're going. Tell some stories about what has worked, some stories about lesson learned. Invite new employees to get on board. Okay, and then the next third piece of workforce development is staff education and training. So this is a leadership issue because only leaders and their HR department can make sure that staff get this training. And some of these trainings can be done in literally 15 minutes. And you guys will all have access to all these PowerPoints if you ever wanted to use them, if you're in a supervisory role, or you ever wanted to, or even an informal leadership role. You could take them apart and you could do mini training sessions at your shift meetings, at your staff meetings. So the public health prevention approach, how that works and why it's important in seclusion restraint prevention. The common assumptions, pull out a couple of those out that Beth talked about. Experiences of staff and adults with seclusion and restraint. Neurobio, roles of consumer, family, and advocates, which you guys, your state, Massachusetts, is one of the leading states in integrating peer support specialists, families, and advocates in all of your facilities. You really, people talk about Massachusetts all the time as, this is one of the places that you guys have like done a beautiful, beautiful job, and we hold you up as the examples in a lot of other places. Negotiation and problem solving. These are not often, people aren't born with these skills. Trauma-informed care, we're not born with that knowledge. Recovery-oriented services, we're not born with that knowledge either. Debriefing, we're not born with that knowledge because these are training issues. Next slide. Seclusion and restraint application training guidelines. So this is pretty interesting. There are literally about 40 vendors. Most of them are either university managed or private for-profit vendors that have developed aggression control training techniques. And you've all heard most of the names: MANT, NAPI, Therapeutic or TCI out of Cornell, PART, UKARU. There's CPI, I think I said, PCI, and there's like over 40 of them. And they're mandated to use by Joint Commission and CMS to make sure that staff have some guidance and skill if you actually have to put hands on to try and keep everybody safe. They're now 20 years, 25 years after the Hartford Current, there are some great vendor training that have completely embraced trauma-informed care and preventing violence. But you need to check that. And the reason I say that is many of these vendor training models use the train the trainer approach. And so what that means is that you pay money and their trainers will come into your facility and they will ask you to choose, 8 people, usually your longer term people that have been around for a long time or a while, to be the trainers. So they will spend 4, 5, 6 days training the trainers to do this work going forward. And then those vendor people leave and you have your own trainers. And then what happens is that training can drift. So I will never forget when I first went to, I think it was the Delaware Psychiatric Institute. And the first couple of days I was there, I went to the de-escalation training. And it was run by 2 very engaged young men who had kind of been elected by their peers to do this training. And the problem was that one of them was a martial arts instructor on his own time. And so that training had morphed from 75% of de-escalation skill development to 75% on how to put people in restraint. And it was disturbing. It was not their fault. That stuff happens. So we had to relearn our aggression control training modules starting immediately. Your aggression control training should basically be 75% on de-escalation skill development and 25% on the safe and as humane as possible use and monitoring of someone in restraint or seclusion. So I know that Massachusetts has its own training and it's a very excellent one. So I'm not as concerned about that, but for any of you who might go somewhere else, just know that if you walk into a new job and they're mostly training fancy martial arts maneuvers that you'll never remember unless you use it all the time, you got a problem. Competencies must accompany the training, and leadership needs to attend this training so they know what information their staff are receiving. Next slide. So in summary, workforce development is a core strategy designed to elevate the oversight of events in real time. And that's again where that morning meeting comes in incredible, and it can only last like 15 minutes. That's all they do in Pennsylvania. They don't even sit down when they come into that meeting in the morning. It's a stand-up 15-minute meeting of what just happened over the last 24 hours. And if something happened and you don't have enough information, someone is directed to go get that information and bring it back for the next morning meeting. So you can constantly close the loop. But going back to witnessing, you want to elevate the oversight of events, to provide you with your own report card, gather as much information you can timely, improve communication and analysis of what happened, and then transfer that learning quickly to policy or practice change. And sometimes you're going to have events that you're not going to learn anything from, and that's just the way it is. So that just, you looked at it, you say, yeah, okay, that's what happened. Nobody did anything that we could really change, we don't think, but let's keep looking at this. The second part of workforce development is to include HR in key roles, or your training department in key roles, to develop your workforce by assuring that your staff receive adequate onboarding, education, training, supervision, feedback, and recognition whenever possible, and then provide training on new knowledge, skills, and attitudes for those folks coming in and toward creating a trauma-informed system of care. And then finally, Stephen Covey, who's a very famous leader, basically said, an empowered organization is one in which individuals have the knowledge, skills, desire, and opportunities to personally succeed in a way that leads to the collective organizational success. So thank you very much. I think I saw a question in the chat. First, I saw it
I'll
flash.
read it. I'll read it, Kevin. It says,
Okay.
will there be, oops, I just lost it. Okay. Will there be any examples, case studies of successful interventions, interactions where staff use their knowledge of the individual patient and program protocols philosophy to de-escalate the situation and generate client cooperation?
Talk about, first off, talk about the CEO in, I think it was in Texas, that knew he was getting that young man in that was really active. Remember?
You want me to tell that story?
Yeah.
Okay, so this was a forensic, well, it's actually, it was a psychiatric hospital that had different units, and it included forensics and included regular hospital units, psychiatric hospital units. And the CEO, or the superintendent, as they call them in Texas, it was this young man who was maybe 28, had been into the hospital 4 or 5 times before. And every time he had been in, he didn't do well with transitions. And every time he had been restrained multiple times. And so this CEO had a 7:30 morning meeting with his entire, this is a big hospital, his entire leadership team. And he had a, he would show the pictures up on a screen of the people who were being admitted that day. And so he has a picture of this young man. I happened to be there that day. And he said, hey, and I don't remember his name, but he said this person has difficulty with transitions, and we've had him multiple times. And this is what I want to have happen. And he pointed to the head of the music department, and he said, I want him to have like his headphones and whatever it was that they give him, and I want it downloaded with country music. I know he likes country music, and I want you to update it once you find out from him what are the songs he really likes, but have that ready for him. And then he said to the nurse manager there, he says, they had it closed courtyards, and this one has a basketball hoop. And he says, I want him to have a basketball available to him 24/7. If he wants to go out and play basketball at 3 a.m, let him play basketball at 3 a.m. And then he said he points to the head of nutrition, and he said to this person, to this woman, he said, I want you to stay out of this. He likes his Oreo cookies. And these next 3 to 4 or 5 days, all I'm concerned about is us providing him with comfort. So make sure he has plenty of snacks, get some Oreo cookies there, find other things that he really likes, and let's focus on comfort for him. So I went to the change of shift meeting there that happened at like 3 o'clock later that afternoon. Everything was implemented. They had the whole piece down. The CEO or the superintendent had come in and checked on this young person. I mean, it was young to me, but so it was, that's a real example of an individual successful intervention. They had their first time he had been in this hospital without a restraint seclusion. Of course, they'd been doing all kinds of other things too, but even the superintendent knew what to do with this person. We have another example of a young girl, maybe 15 years old. Every night she was restrained because she would move her furniture. This was in a program in New York State. She would move her furniture against the door. And so she and the staff would unmove it, get the door open, and then she started again. So they had to sit down and they looked at her history in depth and realized, of course, she had been sexually abused at night in her bedroom. She was trying to keep herself safe. So they worked with her. They actually made a contest so that the kids could earn this huge, huge, huge stuffed animal. And they rigged the contest so she won the stuffed animal. And then so she got to put that and all these other stuffed animals they got for her around her bed. They rearranged the room so she felt safer. And once they did that, she was never restrained at night again. And if she did have a like wanting to rearrange, staff would come in, they'd sit with her, they'd say, what do we need to do? So there's so many examples. Do you guys want to stay till like 2 or 3? Because we could talk, what do you, Minta, I heard you, I saw you shake your head. No, you don't want to say. But anyway, we have many examples where they really use those. And
I have another one. This was about a young woman. She was basically in her mid-20s, and she was what we always label, which I hate this diagnosis, borderline personality disorder. She had an incredibly long history of trauma from the very beginning. And she had a horrible relationship with her parents. It was a really bad situation. And every time she came in, she would live in restraints because she hated men, and she would basically just go after anybody. She would just go after them. And she was really strong. She used to be able to run up the wall into the ceiling. We never figured, I mean, I've never seen anything like this girl before. Nothing, you couldn't engage her. She would engage for like 10 minutes, or you'd become her best friend for 15 minutes. And then she might as well like try and throw something at you or hurt you. So after about 3 or 4 admissions, we got to know her pretty well. And we knew that she liked to do a lot of things, but we couldn't figure out how to have her do them safely. Like she liked to play the piano. She liked to have, she had a dog. She liked to watch TV. She liked to play certain card games, but she was so dangerous that we couldn't figure out how to do it. So this hospital, and this is something that was just kind of circumstantial in a way, situational, because we wouldn't be able to do this in a lot of places, but we had ended up with an empty 10-bed unit because the hospital was getting downsized. So the staff came up with this plan. One of them said, I'll bring in my portable keyboard. We got approval from the health department for her to bring her dog in. We basically set up her own kind of unit. She had a living room, a bedroom, and a bathroom. We had a little nursing station out there. We put 4 nurses or 4 staff there because it was a state hospital, and back in the day we had staff. And she did beautifully. And we also got her external outside community therapist privileges to come in and meet with her 3 times a week. And she started working with her on CBT and DBT. And it wasn't perfect. I mean, she ended up in restraint a couple times. She had a couple more admissions, but the staff led that whole project and just did an incredible job. At one point, she pushed the piano over, and we said, okay, we'll just get another piano. So it was kind of a process of elimination and experiment, but in that particular case, it worked really well for her. And I just heard about a year ago that she had moved into her own apartment and was actually employed. So that's another story. So yes, Minta, you are absolutely right. And you just gave me a really good idea to put more of those examples in on things that staff came up with that really worked and that were individualized for that person in that situation at that time in that environment. That's brilliant.
Yeah, and maybe Kevin, you and I could do a YouTube video with music about all these wonderful examples,
Yeah,
so
right.
people get motivated to do that.
And
Hey, folks, as you're thinking of another question, we're real excited about next Wednesday. We're going to have 2, and this is where also Minta will be able to, you'll hear some questions, you'll hear some presentations with individual examples, because we're going to have 2 different programs. One is an adult hospital and one is a residential program. Leaders from those programs are going to talk about how they moved to prevent, reduce. In fact, Kevin and I are only going to, like, you'll see us rarely. We're going to say hi in the beginning, and then it's all dedicated to these 2 programs. And then the second part is going to be a panel of a family member, peer mentor, a hospital peer mentor, and 1 or 2 youth peer mentors who are going to talk about They're going to answer questions that we give them about the use of restraint and seclusion and what helps and what doesn't help, and the roles of peer mentors in supporting programs and moving forward. So it's one of my favorite sessions, because it's like the people who are doing this work and the people who are experiencing this work. So it's a wonderful, wonderful, next Wednesday is great. And then next Thursday, we actually get to prevention tools, which is really much, much more of, what Brenda had asked about, even more practices to support programs in really gaining, making improvements. So anybody else have any questions or comments? Again, we hope this has been helpful and supportive, and that you can use this information.
And don't forget your evaluations.
Right.
I placed that in the chat, and I will follow up with an email like I did yesterday. And just to repeat something I said yesterday, we did find out we will be able to grant CEUs for individual sessions, so you don't necessarily need to complete all 4 to receive some CEUs. I know.
But we want you to complete all 4.
Yes, we prefer you complete all 4, but you will still be able to receive credit. So please fill it out if you've attended today and you'd like CEUs.
Yeah, please.
Right. But like with any evidence-based program, to just do one portion of it isn't going to give you the framework for real culture change and improvement. But we wish you all the best. We know that this you all have demanding jobs, and the fact that you're spending this time with us means a lot, and it means a lot to the children and adults and families that you serve too. So think about questions.
Yeah, and Minta has her hand up.
I hate to double dip, but I will if no one else has any questions. So a word yesterday and today that I've been hearing a lot in situations that lead to restraint is conflict. And I may just be missing something, but it seems to me like there's a strong association between conflict and restraint. And while obviously conflict often leads to restraints, I think there are other antecedents that may not be conflicts. At least that's what we see here in our program. If somebody believes that conflict is the only situation, or misunderstands, I should say, that the conflict is the only situation where you're going to get a restraint, they're going to miss a lot of escalations and things that will wind up in restraints because there wasn't a specific conflict identified. So I'm wondering, and thinking about that really helpful initial presentation about assumptions about restraint, if there does seem to be a widespread assumption that conflict is sort of the only or the main antecedent for restraint, maybe thinking about talking about that in that list of assumptions, right? There are a lot of other things, feelings the kid has inside. We do have kids, so that's my example. Feelings the kid has inside, a trigger that we're not aware of, right? So there wouldn't be a conflict, and suddenly the kid is throwing objects and there wasn't any interaction with another kid. There may not have been any interaction with staff that was, visible. The kid might be thinking about something they discussed 2 hours earlier in therapy when they were fine and regulated. So hearing the word conflict a lot makes me think that the focus is on restraints that result from a conflict. And we do want to emphasize that whole power struggle thing, because power struggle is so problematic, but there are easily restraints that are not triggered by conflict. And so I'm wondering if it might be helpful to have some attention on that as well.
Thank you, Minta. And maybe just you saying that wants us to emphasize, because I think that we tried to emphasize that, say, throughout the trauma-informed care piece about, like when we don't know what's happening inside. We do not, know. But so I think that I'm not sure that we're going to find the research about that, but we definitely should be more careful if that's coming across, because the whole piece of trauma and how it changes the brains. That there could be nothing, as you said in the examples we gave there wasn't necessarily. And so it was an all internal viewing that was happening in the young girl's head who was in math class and the young man who was in the hospital. So I think that's an excellent point for everybody to understand, and we'll be more aware of that too, that came across. I think in risk factors, that is a lot about conflict, and a lot of the research is from that piece of it. But I think your point is absolutely consistent with what we're saying, and we'll try to really make sure that that people don't get that sense. And I'm not sure we can put in assumptions, but we'll definitely look at it in terms of, some of the research is on trauma. So yes,
Yeah.
we'll definitely look at it. So thank you. And Dana, Minta now gets 2 gift certificates because, Brenna has her hand up again. Thank you, Minta, for that. Really important to note that.
There, I know we're right at the end of our time, so not so much a question as something that I'm kind of hoping will be in the upcoming trainings. Working in an inpatient setting, we've seen a lot of folks come in with harm created by involuntary hospitalization or trauma associated with prior restraints. And I wanted to know just about like restorative justice practices that we can embrace in that setting and ways of reducing that type of risk and harm.
Yeah, that's a great question. We talk about decontaminating past experiences as part of the admission process. Saying, I'm really sorry that this has happened, that you've had to, come here. How can we make this as pleasant as possible? Having the person talk, if they want to, about their past experiences. You can learn more about them and their story, which a lot of people never really have anybody that even cares about listening to their story. That whole piece on apology from Dr. Lazier, who wrote the book on apology in healthcare situations where after an event happens, you basically say, I'm so sorry that happened to you. Can we talk about how we could have done something differently, sharing the responsibility for that, and really, especially like in the just past position I held running community-based 24-hour crisis service programs like psychiatric emergency rooms where the police would bring people in handcuffs and often somewhat roughed up. We would immediately start that at the beginning by saying, I'm so sorry that happened. Please get the handcuffs off. Can I get you something to drink? Can I get you something to eat? What's your name? My name's Kevin. I'm a nurse. What can we do to this is a safe place for you. Get the police out as soon as we possibly could. So I totally understand what you're talking about, Brenna. It's super important to try and decontaminate that and the whole concept of restorative justice. So we will be talking about that a little bit more in terms of the debriefing PowerPoint. We talk about ways to go about that. So I hope that will be helpful, and I will keep that in mind as we move forward and that actually might be a really good question to ask the peers on, what helped them trust the staff, even if they'd had really bad experiences before. So thank you.
Okay, what's everybody going to remember to do as soon as you stand up? Move your body before your next. Any last comments or questions? Okay, thank you, everybody.
Thanks.
Really appreciate it. See